Welcome. So this is a video about achalasia assessment. So I think you really can assess achalasia using endoscopic imaging. So there are lots of surrogate features which indicate that a patient has achalasia. So I've just done a tour of the esophagus. What have you seen so far? You've seen fluid present. Here you have the stomach. You have absolutely no evidence of our hiatus hernia, and the endoscope is being hugged, if you like, or is really being gripped by the lower esophageal sphincter, which actually, even looking here, is quite developed. Right? You can see that. And it's not so easy. You really can stretch it with the endoscope, but it's not so easy to do that. So it's quite hugging the scope. So if we break it down, 2 or 3 minutes about what achalasia looks like with endoscopic imaging. Here we're using a Fujifilm zoom endoscope of 760 type. First thing, saliva present in the proximal esophagus. So this is possibly normal, but in combination with the other findings which we're about to show is potentially not normal. As we continue down, you have a deformed esophagus. And then you have this very interesting appearance that starts here. So you might think, well, this is Barrett's esophagus, right? I mean, this is for sure easy to confuse with Barrett's esophagus. It looks a bit like it, right? And as we come down more, we have a lot of fluid. And so the presence of fluid and this degree of fluid stasis in an esophagus in a patient who has fasted acceptably is not normal. So that's one thing, the stasis of saliva, the stasis of fluid, of course, also the stasis of food, and there are food matter here. But this appearance is very interesting. So maybe we suck out the fluid to get a better view, and maybe this will cause a problem with the degree of food stasis. But what are you seeing, just while we do this, what are you seeing, Pitian, in terms of the mucosa? So the mucosa about halfway down the esophagus ceases to be normal. It's about the level of the food, right, or the fluid, so almost certainly it's that sort of phenomenon associated with that. But what are you seeing? And we'll get some better imaging.
So you see at the proximal esophagus, you see the normal squamous epithelium, which looks a bit paler, but looks quite smooth. But once you go down more, you have a sort of wobbly appearance where you have some thicker plaques, some thinner parts. It's like it's chronically inflamed.
Yeah, I mean it's like skin that's been in a bath too long, and I think it's a good analogy because this is also squamous mucosa, just like the skin, and it just looks like it's peeling the surface. You have that exudative attachment. It's all the way actually in this esophagus, all the way, so we can actually quantify. So here you have probably the top of it here. So we're right up at 22 centimeters from the interstices. As we come down, right down to the gastroesophageal junction, which is here, and this is at 48 or something like that. So a lot of it, and if you look under narrowband imaging, BLI, eye scan, in this case BLI because we are using Fujifilm, then what do you see? You probably see an inflammatory IPCL pattern. And if we can find this, that would be nice. So you see it, I think you clearly see it here. You have IPCLs which are regular, but which are hyperchromatic, so they are more brown than the standard IPCLs. And you can go searching for those. Of course, these patients are at risk of cancer within, and here's actually some different type of mucosa. You can clearly see the pattern here, the dilated IPCL pattern, but that is inflammatory rather than malignant in type, because they remain regular, and it's visible throughout. But what is also visible is the surface exudate, which is clear, and the crinkled, almost papier-mâché appearance of the esophagus.
Some scaling of the.
So one thing you must do in patients with achalasia is look for evidence of cancer. How can we do that? Well, we're going to look for, it's not going to be raised probably, it's probably going to be a flat plaque, and LCI is great for that. You can see that it's accentuated in the background, that exudate is clearly visible. We have quite a bit of glare. We could turn off the hardcore view, but I do think it's still a great view here. And we can see the position of the, I mean, it's important to say, you can see the position of the spine here. You can see the vertebrae, right, clearly in this esophagus. That's obviously marking the 6 o'clock position. If you need any kind of landmarking for your positionality. And then while LCI is okay, the other thing you should do is do that with BLI or a characterization mode. And actually a lot of people we're talking about withdrawing the scope up the esophagus using that mode, right? So this is BLI, this is a characterization mode. This is going to pull out in more dark areas which are hyperchromatic, which contain more blood vessels, which are hypervascular, and these areas are targets for closer inspection, right? So like here, for example, which I think we already inspected, but if we didn't, we can go closer. We can use the cap, because we have a cap on, to sort the focal length, and we can see these IPCLs here. They are not irregular, they are, in my view, just dilated. If you want a better image of that, you could use underwater imaging, but we're not going to do that here. Okay, right. And then the final aspect is the sphincter assessment, I think. So this is something which you can do, but all of these things so far, so the inflammation, the food stasis, all of this is surrogate features that there's some obstructive component. So you're looking for something. It could be a tumor, obviously, but it doesn't look like there's anything intraluminal anyway. Of course, we need cross-sectional imaging, but it doesn't look like we see something. And then you have a junction assessment. So sometimes when you push in, you get resistance. Here we have a little bit, but it's not major. This patient has achalasia. This patient has had treatment before. That can be the reason why we don't see the naive type appearance. But this patient clearly has evidence of current stasis. And then we already covered this, but it's very, very important to obtain this image of the junction and see what you can do in terms of stretch so that you can exclude achalasia. Almost certainly you can exclude achalasia if there is a big gap here or there is a hiatus hernia here. All right. So any questions you've got, Pitian, or something about that that's not clear about the endoscopic assessment of achalasia?
No, I think that was quite clear, to be honest.
Perfect. All right. Well, I hope you enjoyed this. We're going to perform mytomy, endoscopic mytomy on this patient, and we can show you the result of that. But yeah, I think this video, just to illustrate that there are clear endoscopic features of achalasia, which you should describe in your endoscopy report, and that is very, very useful in terms of the workup of these patients. All right. Thanks for watching.